Welcome to another episode of What Brings You In Today.
I'm Erica Bennett.
And I'm Taylor Fisher.
And we just want to thank all of our listeners for tuning in. And if you haven't already, please subscribe and like our podcast so that you can stay up to date with all of our new episodes.
Yes. And if you have any questions or topics you would like to submit, you can do so at sgmc.org/podcast.
All right. Well, today we have Dr. Leslie Holmes, radiation oncologist at SGMC Health's Pearlman Cancer Center with us. So, Dr. Holmes, what brings you in today?
I'm here to talk about the fabulous things that radiation oncology can offer our patients.
All right. So let's just hit the first question. What is radiation oncology for the average listener that knows nothing?
Okay. Radiation therapy uses the power of radiation therapy, and a big word would be photons, but basically we remember the cells and the nucleus and the protons and electrons.
I don't remember them very well, but I do remember the names.
But what we do is we take electrons, which is part of a cell, and we accelerate them and make them move really, really fast down a tube, and then we smash them into a specific target, and we create photons. And those photons are way stronger. You could think of them as sun rays, but they're 1,000,000 times more stronger than that. And we use that ability to treat cancer cells.
Wow.
That's so fascinating.
I had no idea that's what that was.
Me neither. I'm like, okay, I know we do radiation oncology. I have no idea what that means. But
Dr. Holmes, can you tell us a little bit about you? Now that we know what radiation oncology is, can you tell us about your background and how you got to SGMC Health?
Well, I'm from New Jersey originally. I'm a graduate of Howard University. And then I was accepted to Morehouse School of Medicine, which is in the great town of Atlanta, Georgia, and one of the premises of our school was to help the underserved, and I've dedicated my career to doing so, and this was a perfect opportunity for me to come here. Also, one of the mantras of our school is they would like us to serve the area unto which they graduated from, and so that's what brought me back to Georgia. And so I'd like to serve this community, and I found it a great place to be, and it's been a wonderful experience thus far.
And all the different specialties as you're going through medical school that you can choose to, focus on and become what your career and your life's work. What drove you to radiation oncology?
Well, it started in my undergraduate matriculation. I'm a radiation therapist. I was the one that was delivering the actual treatment that the physician prescribed. But while I was in that role and I was learning how to be a therapist, I had some great mentors around me, the physicians, and I saw how they interacted with the patients, how much joy they brought the patients, how the outcomes were, how thankful the patients were. They were thankful at the therapist level as well, but I wanted to be more involved with the care and decision making upon their care. And so that promoted me to go to medical school to become a physician so that I could be a radiation oncologist.
Wow. I wouldn't have thought of that even as a specialty, I guess, whenever I was deciding.
No.
But, we're so glad that we have radiation oncologists.
What's the most type of cancer that you treat in your specialty?
The majority of the cancers that we treat are breast, lung cancer, and prostate cancer. Those are the top three, and those are the main ones we focus on. We do a lot of GI cancers as well. We treat a lot of esophageal cancer, pancreatic, anal, and rectal cancers as well.
Let's talk about breast cancer because that one's huge, widely advertised, promoted as far as screenings and making sure you're, how important is it that they get a mammogram and get it recognized early?
Yes. The whole premise of screening tests, and we don't have that many, we'll focus on breast mainly when we talk, but there are only a few screening tests out there. We have the mammogram for breast cancer. We have the pap smear for cervical cancer. And we have the colonoscopy for colon cancer. And we have the low-dose CT screening for lung cancer. And that's about it. That's what we have. And so we encourage patients to talk with their primary care physician and really undergo those screening tests so that disease can be identified early and it can be identified in an early stage. The earlier the stage, the better the treatments that we have for them, the more control, and that helps to contribute to one's survival with controlled disease or obliterating the disease completely.
No, I feel like most people are not, a majority of people would just be scared to find out. Like what you don't know, it can't bother you. And so you just kind of live without knowing.
But that's the thought process of patients.
Right.
Okay. If it's not broke, don't fix it. But we have the ability to have screenings. And if you know what you have, you can deal with it early on. And yes, it is a little difficult to obtain that diagnosis and to be taught about that diagnosis and to be told that you have a diagnosis of cancer. But here at SGMC Health, you have a whole cancer center, and everyone there is dedicated to helping you fight your disease process. And everyone there involved, no matter what level, from the valet person at that accepts you at the front door with a warm greeting from the receptionist, to all the physicians, the nursing staff, the therapists, the nurse practitioners, the navigators. There's a whole team there that helps you work through your process. We have social workers, dietitians, so we look at the patient as a whole, and we hold your hand because we do know that it's scary. But our passion for developing the care for you and your treatment plan will help guide you through, and we give you a great support system that you can rely upon so that you can deal with that difficult news, because it is difficult to deal with, so that you can get well.
I imagine that would be hard, and I feel like I've heard some doctors speak about particular cases of patients that they've received that it was just so late in the diagnosis, and they just wish so much, that they could have found that earlier. So I guess to that point, if you are nervous about it, you would probably feel so much worse about it if you just put it off because you were being kind of hard-headed,
Exactly,
I'll say, or just kind of,
or apprehensive, or fear. Fear does consume.
It drives a lot.
It does drive a lot, and denial drives a lot as well, and it is frightening. But that's why you go to the doctor, because they are trained to help you get through your woes.
So
regarding your health.
What are the recommendations as far as screenings go? Like what age, or, are there any other factors that you should start getting screened?
Well, you have to follow up with your primary care physician, and you have to have a good relationship with them. And they're the ones that will guide you to say, hey, it's time for your colonoscopy screening, and the guidelines are changing quite frequently. If you have a family history, maybe you have to start a little earlier than what the guidelines say, just because you have a family history of disease process. So you really need to build that relationship with your primary care physician. And even me, I'm a radiation oncologist, but you may have come to me for colon cancer or rectal cancer that was found oddly, but then I may say to you, hey, have you ever had a mammogram? You're a smoker. Have you ever had a low-dose CT? Just because I'm a specialist and I'm treating this one site doesn't mean I don't care about you as a whole. So I refer patients to their primary care physician, the American Cancer Society, and they can follow all of the guidelines that help you with screenings.
I know one of the things that we've implemented pretty recently or just really focused on is care gaps and within our electronic health record to help our primary care doctors see when a patient has not had, if they qualify for those certain things, to make sure they're having that conversation with the patient. And it's not because we just want patients to get more things done. I mean, it's because we want the patients to take care of themselves and be proactive and be a advocate for their health.
Right. I received my health care in the South Georgia medical system, and I've used that care gap system myself, to say, oh, hey, I got to make an appointment. I have to do this. I have to get an eye exam. And those prompts are very, very helpful in one's health.
to just hold you accountable. So the MyChart, so if you're a patient anywhere within our system, you get access to MyChart, which is, I think, one of the leading electronic health records in the nation. But so there's so many people using it that they're always, advancing it and making it be,
refining it to get better.
Refining it to meet all the patient's needs. But it's really cool because not only can you get like your lab results before the doctor even gets into the room, which can be good or bad. But, you do get those reminders. And I think that does help you if you have that mindset, like, I'm going to be proactive. I'm going to go to my primary every year. I'm going to get, whatever I'm supposed to be getting just to be your little reminder.
Right. But it's a great reminder. And healthcare, I tell patients all the time, healthcare is a two-way street. Someone didn't call you with a result. It's up to you to pick up the phone because the health staff, they get busy. And it's not that they forget about you, but you have to take care of you. And you are the most important for yourself. And you need to be an advocate for yourself. So if you don't hear something, or if you have a question, no question is too small, no question is stupid, pick up the phone and ask. And the team here really helps you.
I totally agree.
Yeah, I think it's a great message because they're like, well, I'm not going to call, they'll call me or whatever. And we don't want everybody to falsely be overly calling. But if you have a concern or something, don't be timid about speaking up for yourself.
I agree.
At your doctor's appointments or, if you just have something else.
Exactly.
I agree. Are there any recent advancements or any new technology as far as in the field of radiation oncology that we're seeing are being used more often now that are beneficial?
Yes, we have the advancement of intensity modulated radiation therapy, which basically we can use tighter margins. It used to, when I was in training, we used large fields to treat areas, and we have to be concerned about the normal tissue tolerance. Now, the difference between a cancer cell and a normal cell is that a cancer cell cannot repair the radiation damage, so we use that factor of radiation to treat the cancer. It's because the cancer cells can't repair radiation damage, but normal cells can repair radiation damage. And so what happens is we don't necessarily want to treat too many normal cells because why do we have to put the patient through that toxicity? So what was invented was IMRT, where we could treat the cancer and put a tighter margin around it and still have some normal tissue in the field, but not as much as we used to before. And now we've even made the fields tighter and smaller depending on the disease process. We can use stereotactic radiosurgery to treat a lot of the brain tumors that we receive in consultation, and we can also use that same premise and call it stereotactic body radiosurgery, where we can treat tighter margins and really refine the tumor and have pencil beams specifically to the tumor for tumors that are in the body area. And then now what we're doing is we're using larger fractionations of treatment. So we give a little bit higher dose than our conventional treatment. And what that does over time, it's biologically equivalent to the longer course of treatment. But now we can deliver that same treatment in a shorter period of time because we realize that radiation therapy is usually delivered Monday through Friday. And so when I was in residency, it was like 8 weeks of treatment for some sites, 7 weeks of treatments for some sites, 6 weeks of treatments for some sites, but now we've reduced that because we give a little higher dose in a shorter period of time, which is equivalent to giving that same dose over a longer period of time. And then what we can do is shorten the time frame unto which the patient has to give up their life per se to come in for treatment. And that makes their quality of life better, their overall outcome better. Because they don't have to spend so much time in the hospital and the clinics and outpatient clinics.
It's so refreshing just seeing this, and we've heard this from many specialties, from heart to neurosurgery to interventional physiatry, but everything is evolving with the patient in mind to really help with that experience. And we don't want them to have to be here unnecessarily or longer than they have to. And I think that's really cool that we're moving in that direction. And speaking of like radiation, what about the equipment, the technology that you
use? We use the linear accelerator, which, like I said, it basically does what it says. It's a large machine. It looks similar to a CT unit, and it rotates around the patient. And the patient does not have to move. They just have to lay relaxed on the treatment table. We used to have to put these big lead blocks into the head of the machine, but we no longer have to do that because in the head of the machine, we have these leaves that move and they block the normal tissues out and expose the tumor. And so
That's nice.
yes, and it used to be
less work on the staff.
exactly. You used to have to lay on the table for half an hour. Now you can get treated in like 10 minutes. Yeah, so the actual deliverance of the treatment itself, the actual beam on time is about a minute. But we do take our time seriously to make sure you are set up properly, and that can take about 10 or 15 minutes, but it's not as ominous as it used to be. So the treatments are shorter, the time frame unto which the treatment, the period of time a patient is getting treated is much shorter, and it's very well tolerated, and patients do have side effects from treatment depending on the site, but they're not as severe as they used to be.
Well, that's good because is cancer scary enough as it is without the actual treatment part being scary?
What's the difference? So, and I only know a little bit about this because we had to put this on our website. But when it comes to cancer care, you have like medical oncologist and radiation oncologist. Tell us maybe just high level, like what the difference is when one might see a medical oncologist first, or do you see both? And
Okay. So most cancer patients are treated in a multidisciplinary approach. And the three disciplines mainly that treat cancer are surgery, medical oncology, and radiation oncology. And we rely very heavily on our pathologists that read the specimens and tell us exactly what we need to treat. And we also rely very heavily on our radiologists because we order a lot of scans. But the actual therapeutic treatment, the actual treatment delivery are from surgery, medical oncology, and radiation oncology. Surgery, we all know, that's with a scalpel, right? That's where we remove the disease through surgical intervention, or we cut it out, okay? And then you have medical oncology and radiation oncology. And medical oncology usually delivers a drug, chemotherapy, or immunotherapy, and that goes through the veins and circulates the entire body, okay? Whereby radiation therapy uses radiation, and we pinpoint the treatment, and it's more for local control to decrease the chance of the cancer returning where it started. Okay, so those are the difference.
That makes total sense, but I guess I hadn't really thought about it. But I've definitely heard of chemo, often in treatment and radiation. But and then do you ever have to do both?
Lots of patients do. That's why we have tumor boards here. And we present our cases in tumor boards, and all of the doctors come together. We review the pathology slides, the x-rays, the CTs, the MRIs, the PET scans, and then all of the colleagues come together and we confer with one another. And we talk about the case and the pros and cons of delivering treatment and what's the best treatment for the patient. And we come to a consensus, and that is the treatment plan for the patient, and we roll that out.
It always fascinates me. I used to have to walk by the cancer center every day to get to my office, and or just during the day. And the patients were always that's generally like had very good attitudes. The people in the cancer center are just like often described as angels on earth. We get a lot of positive, reviews from our cancer center. But what is it like working in a space, that you would think would be very emotionally draining? Like, how do you deal with that? Like, how do you go about your day?
Well, I try to be as optimistic as possible. Nobody wants to come in and have a doctor that's downtrodden and, woe was me and beat down. And so my thing is, if you remain optimistic, your patients will reflect that. And if you are a cheerleader for your patients will appreciate that. And I always tell patients, hey, I know there's going to be days when you're going to cry, or you're going to think, why am I going through this? Or why? But for the most part of it, have an optimistic outlook, because if you do, that will help you get better. and hold on to that and be prayerful as well, because that helps a lot as well.
Yeah.
I think you have a great personality for that job, because I just always see you in the hallway and you're smiling, or you'll say, cute outfit, or you
I
always,
know, I'm always just trying to figure out what you're wearing.
you're always dressed
How many
cute.
pairs of glasses do you have?
Quite a few.
Because they're always stylish.
So I can see how you would be that way to your patients and positive, and they would reflect that because of how you are, and you
Y'all,
just kind
thank
of, you
you.
glow.
I
So-
appreciate that. Thank you.
What's the most gratifying part of your job?
I think the most gratifying part is when a patient says thank you. Just simply thank you. That they're appreciative of the services provided. They express their gratitude to us. We have surveys that are done on us, and patients write a lot of accolades, not just for me, but for most of the physicians in the office, and the whole cancer center as a whole. And we really, really try to bring a bright place for someone that's going through a catastrophic illness. And
What would you say to people that that don't know that we have a cancer center, or the caliber of cancer center that we have here? I mean, you think about those that have much higher name recognition or advertised nationally, like Cancer Centers of America or something like that. But how would you compare what we are able to provide, and the importance of being able to get that treatment locally versus traveling?
well, we can do whatever the high-powered centers or tertiary care centers can do. We can deliver that care right here in your back door, and you don't have to go to a tertiary care center for everything. You don't have to go to the high-powered name centers for everything. We are a community-based centers, but we have very well-trained physicians. Everyone here is board certified, and you can trust the fact that they are here to deliver first-class care to you. Now, that being said, if it's something that we can't deliver, we do have a relationship with all of those tertiary care centers. And so we do have that. And sometimes we have colleagues out there, and we can call them on the back end and say, hey, let me run this by you, and I just want to double check.
Yeah.
And I always read the national guidelines. They are reviewed regularly. We talk about them in tumor board, and we don't go astray from those national guidelines. And those tertiary care centers, they're using the same guidelines
Right.
that we're using. So for the most part, you can receive your care right here. You don't have to travel afar.
Yeah, and I think when receiving care, such as cancer care, you don't want to be very far from home if you can help it. You want to be near your support system.
You do.
Because you're having to go several appointments, whether it's weekly or, more than that. I know my father-in-law received chemo here, and it was just nice. I mean, I know I work here, but I was able to go drop in and see him while he was getting chemo. And I've just known several patients that have utilized our services, and, they're always just raving and so grateful that they were able to get that here.
Right. It's nice to go home at the end of the day. You've had a hard day of treatment, and it's nice to go home and eat your own dinner and sleep in your own bed.
Well, not have the added expense of like a hotel or the travel.
Exactly, because that does make one weary.
Yeah.
But it's right here, and it's the best care, and we love delivering it.
I do have a question specifically about breast cancer, because I feel like just from the people in my circle that I'm seeing more younger women.
I'm glad you said that, because I was wanting to ask that too.
Yes, that are testing positive, or, having breast cancer, like even into their 20s. I've had, friends that were around my age, 29, and having to have all these treatments. And I mean, do you know anything like medically, like why that could be?
What would be attributing the
so prevalent, or any
younger
words
age
about
group?
that?
I think that the whole diagnosing early is an evolution of education. I think that we are more aware of breast cancer when Susan G. Komen came out and and American Cancer Society, and then they realized, hey, women are being diagnosed at late stages. We need to get on this early. And so with the education that's out there, with social media that's out there, with the television and the advertisements, and October being Breast Cancer Awareness Month, it's advertised everywhere. And so I just think that people are more educated about the disease process. I think that we're more aware. I think that the world in general has been made comfortable to talk about screenings and breast cancer, and so that makes it more amenable. One of the fallacies in screening for breast cancer is that the technology we have is good, but it doesn't work very well with the density of the breast, and younger women have more dense breast tissue. That's why they say start at age 40 for the
I was
screenings.
wondering why they haven't decided to lower it, just because there's been more. But the ones that I know that have been younger have typically found because they've felt something. And
Yes. And it's hard. The technologies that are available work better with less dense breast tissue. But hopefully on the horizon,
That'll evolve.
there's new, I think it's a 3D mammogram that's coming out now. And so that may help. And now we've incorporated the MRI. We're using ultrasound much more. And then we're educating patients on doing self-breast exams. You have to do a self-breast exam. You do it once a month. You go to your clinician. They do it for you as well. And then you start with your screenings earlier. But if you feel something odd, go get it worked up. Just don't blow it off as, oh, I'm 20 or I'm 25 and I can't possibly have that. Because cancer does not follow the textbook.
Yeah, and worst comes to worst, I mean, best news is nothing, and then you never have to worry about it.
Yes.
Worst case, it is something, but you identified it early.
Yes, exactly.
Yes. I had that case with my very best friend. Shout out Katie. We've been friends since we were kids, but she has a family history of fibroids in her breast. So she, at 24, 25 maybe, felt a lump and immediately went and had, her doctor look at it. They did ultrasound. They did what do you call it, where they test the biopsy. Everything came back normal. It was just a fibroid. But, I mean, at that young, you think, oh, this can't be breast cancer.
But fibroadenomas are very common in young breast tissue. And so you just have to be aware of that. And like I said, education is key. But going to the doctor, figuring out what it is, being early on helps. No, and I'd rather pay and find out it's nothing than have a monstrosity.
Right.
And find out that it's something later on.
Well, and because the treatment is so much less if you can catch it early, right?
Exactly.
The tools that you have to utilize.
And you asked earlier another advancement for breast cancer. We're doing more breast-conserving therapy now. Now what they're doing is they are just removing the mass more, and they're taking a little tissue around that, and then you follow that up with radiation therapy. Okay,
as opposed to like a total mastectomy,
versus doing a mastectomy. The convention now is to try to save the native breast tissue if you can. And what the beauty of that is having breast conserving therapy. That's what it's called. Breast conserving therapy has the exact same outcome as a mastectomy, but when you don't have to go through the big major surgery. And even though you get a mastectomy and you think, oh, I'll just have my breast removed and I won't get this, you can't remove all the breast tissue when you do a mastectomy. You remove the majority of it, but remember, it only takes one cancer cell. One breast cell to change to wreak havoc. So, but the outcomes of having a mastectomy is exactly the same as having, we call it a lumpectomy or a partial mastectomy, or removing the tumor with a little normal tissue around it and adding radiation therapy onto that. You have the exact same outcome as you would.
Well, that's good to know because I had no idea. I've seen women just, I'll just get them completely removed
Yeah.
because you think that it can't happen again, but I didn't know that that was still possible.
It is possible.
Well, I know
And also, depending on what they find out pathologically, doesn't negate the fact that you might not need radiation if you had a mastectomy as well. So you just have to be patient with yourself.
Well, and that's what having a team such as yourself on it, you're not expected to know everything as the patient. That's what your team is there for, to help guide you through that. And that definitely gives confidence to the patient to know that we have a whole team of providers that are really focused on the best outcomes for
Yes.
them. We have, we do every year patient testimonials during Breast Cancer Awareness Month, where we'll take like 4 usually and share one every week. But I'm always in awe of those patients, like their stories and just their strength and mental fortitude that they have going through that. I mean, it always just like almost brings me to tears, some of their stories, because nobody wants to have to go through that, but they always come out just like so strong and just just with so much power. Anyways, I don't know. I just think that's really cool. So if you have not heard, or if you want to read some of those stories, we always have those on our website. But I would also echo that you probably, just for inspiration, if you are going through breast cancer diagnosis or, want to kind of hear from others and get that support group, because I feel like that's probably equally important, is having a good support group.
Very good. Mm-hmm.
And we do have cancer support groups at our cancer center. We have that information on our website under our events as well. So thank you, Dr. Holmes, for joining us
for
today.
having me.
I have one last question. I know we need to wrap up because we're getting close to our time, but I wanted to ask, what is your favorite meal to eat here, either in the Spice or the cafeteria?
They got rid of my favorite meal.
Oh, no. Well, hey, they might bring it back. Tell us what it was. We have pool around here. We know who comes up with the menus.
It's very bad, but it was my guilty pleasure, and it was a grilled hot dog.
Oh. Did they just get rid of hot dogs all together?
They kept the corn dogs, but
Oh, okay. We'll
have
that
to talk
happen.
to somebody
I think
about
we can figure
that.
that out. I think we can probably make that happen. But
it was my guilty pleasure. I'm not supposed to have it, but that's
Do you
what
have
I
a backup now? Do you have another
grilled
fan?
cheese with bacon.
Oh,
That's
grilled
my
cheese
other
with
comfort
Okay.
food.
Nice.
That's
They have
good.
some good comfort food. If you're stressed out, you can go over there and get you something to help.
At the Spice.
Yes.
Well, thank you again for joining us. Thank you, everyone, for listening. And if you like the show and you want to hear more, please like and subscribe so you can get those episodes downloaded and stay up to date with what's going on with us.
Yeah, and if you need more information about the Pearlman Cancer Center or Dr. Holmes, we will provide her information below so that you can learn more. Thank you.
Thank you.